Good day, everyone, and welcome to our webinar today entitled Urinary Incontinence, Causes, Treatments, and Management Solutions. And as always, this webinar is brought to you by a consortium of sponsors, including Care Choices, Hospice and Palliative Services, O'Connor Mortuary, Caring Companions at Home, and Alzheimer's Orange County. And I'm Kim Bailey with Alzheimer's Orange County, and I am your host today. As you know, our sponsors have been providing these webinars as a service to the community with various topics that are beneficial for anyone who is caring for someone or working in the industry with older adults. So I think you're going to find today's presentation especially informative and useful. And with that said, let me go ahead and tell you about our wonderful presenter. Her name is Donna Thompson, and she's a certified family nurse practitioner and certified advanced practice continence care nurse who has been in this field for over 25 years. She has recently retired as a nurse practitioner with a 5-physician faculty practice at University of Pennsylvania Division of Urogynecology in Philadelphia. Prior to joining Penn, Donna was part of a urology practice that included urology rounds in a large long-term care facility, and she also started her own consulting business called Continence Solutions, which provided continence services to nursing homes, assisted living facilities, continuing care retirement communities, and a life at home program. She has authored numerous publications in the specialty, which included chapters in the core curriculums of the Society of Urologic Nurses and Associates on geriatric urology and wound ostomy, Continence Nurses Society on fundamentals of continence care. She served as president of the WOC-NCB, the certification board of the WOCN, as a member of the board of directors of SUNYA, chaired conference planning committees, been a speaker at a number of local and national conferences, and has received the 2014 Rodney Apple Continence Champion Award for the National Association for Continence. She is now enjoying some of her retirement time with her kids and doing some consulting on the side. And here is our speaker, Donna. And Donna, I do apologize. I think I stumbled on a few of those impressive credentials of yours, but we are absolutely thrilled to have you, and I'll turn the presentation over to you.
Thank you, and thank you very much for hosting me on this program, and I'm really honored to be here with all of you. So let's talk about incontinence. Incontinence is really a very common problem. It occurs in about 60% of women. It increases with age. It's very common in elderly persons in residential facilities, and unfortunately is an expected part of dementia as it progresses. And it's no surprise that it's very expensive. And I'm not just talking about medical care and medical evaluation. I'm really talking about some of those other costs, such as containment products and continence care, and just the burden of caregiving. It affects quality of life. And I can say that over 25 years plus, I've really seen this in very real ways. There's an association with depression and anxiety. It really impacts self-esteem, sexuality, and relationships. There's significant embarrassment and shame. I have patients that don't want to go out, that won't go to family events, that don't even want to go to weddings in the family because of their fear of an accident. It does interfere with daily life and activity, and believe it or not, negatively impacts work productivity. And it was just a shame that I actually had to write a prescription for somebody once so they could go to the bathroom during work hours. Well, let's get our terminology straight. This is pretty simple. Urinary incontinence is involuntary leakage of urine. But I'd like to explain it more like it's storage failure. It's the inability to hold urine for whatever the cause. Well, let's go into that a little bit more. What is it? It's a failure to store. And you've heard on the radio all over, overactive bladder, gotta go, gotta go. Well, yeah, the bladder cannot hold because the bladder's over contracting. But it can also be a failure to empty, or something called underactive bladder or underactivity. And I've seen that a lot in frail elders. But it can also be a failure of the urethra to hold urine. And that could be a failure to store or to empty due to such things as obstruction. What comes to mind is something like prostatic obstruction from BPH. Or it could be an incompetent sphincter. The muscle does not stay tight enough to control urine, or it could be pelvic floor disorder. So there's a lot of different things that can cause it. There's some other terminology that you may hear out there called LUTs. You know, in medicine, we love to have an acronym. So here's one of ours. And it really talks about lower urinary tract symptoms. And one of those may be bladder holding, bladder emptying. And you can see some of the symptoms are the same, some are slightly different, which makes diagnosis a little bit dicey sometimes. But we have such things as incontinence, frequency, which is frequent urination more than usual, urgency, small volume voiding, and uresis, which means voiding when without waking up. Incontinence such as also weak stream, dribbling, hesitancy, which is when you get to the toilet, you wait and you hope it comes soon. Straining, which is pushing to void and or urinary retention. There's other symptoms such as pain, dysuria, which is painful urination, and polyuria, excessive urine production. We know, and we've heard so much about stress incontinence, that involuntary loss of urine, and classically people say, well, I leak when I cough and sneeze. I laugh so hard myself, but it can also be with any kind of effort or exertion. And sometimes I have patients that say, well, I don't cough or sneeze, but I'll ask them, do you leak when you get out of a chair? Do you leak when you walk across the floor? Do you leak when you bend over? Okay, these are some of the symptoms of stress incontinence. Urgency incontinence or urge incontinence is, again, in that involuntary loss of urine, but it's associated with urgency. And how I explain it is gotta go, gotta go, gotta go. All right. One of the things that we talk about is key in the lock, which means you get to that front door and oops, out it comes. You'll leak with removing clothing, running water, and getting up at night to pass urine is very, very common. We've heard over and over again from the radio, the television, it's overactive bladder, OAB. And this can be overactive bladder or leakage, or symptoms that can be either OAB wet, which is associated with incontinence, or OAB dry, which is those very bothersome symptoms of urgency and frequency. But we need to quantify that it isn't with a urinary infection or some other disease. There's mixed incontinence, a little bit of both, urge and stress. And then there's overflow incontinence, which I actually see with frail elders more often than I do in my office population. And what that is the patients will develop an overly full bladder, and like a dam, it'll dribble over the edge. Overflow incontinence. There are normal age-related changes that contribute to incontinence. Now, I didn't say cause incontinence, I said contribute. And we have to understand, especially for the very old, we have problems with decreased capacity for the bladder, decreased sensation of filling. They may have more overactivity. And I used to do bladder testing, and you could see that. And I say, did you feel that? And they go, oh, no, everything's fine. They have a decreased contractile function, which means their ability to squeeze urine out of their bladder is less, and increased PVR, which stands for post-void residual. There'll be, in women, decreased estrogen, and there's a fancy new term. We used to call it atrophic vaginitis, but now it's called genitourinary syndrome of menopause, which includes the symptoms of urgency, dysuria, painful urination, and recurrent UTIs. We know that our frail older adults tend to have altered immune function. And we can have abnormality in the urethra, which is in women a decreased closure pressure, and in men obstruction due to BPH or benign prostatic hypertrophy or prostate cancer. And I do tell my older adults, I said, it is normal to get up at least once during the night, but you may indeed have more than that as we age. But as a general rule, it is normal to get up at least once. There are a number of risk factors that are associated with incontinence, and that's something that people don't really pay much attention to. And what comes to mind most often is the things that I see are things like diabetes, bowel dysfunction, heart failure. Now, associated with heart failure, one of the things that comes to mind is nocturia, a lot of increased urine production at night, obesity, dementia, depression, anxiety. All of these things are risk factors. They don't cause incontinence. They just can contribute to it. There are a lot of medications that impact continence, and that's something that we should always keep in mind. Now, I'm not going to go through these in detail, but the first one on the list sort of is gee whiz, Donna, we knew that. But that is urgency and frequency associated with diuretics. And we see that, especially with the loop diuretics. Fluid retention, we don't often think about fluid retention, but there's a number of drugs that also do that. Urinary retention, the kind of an example that I give you here is the gentleman with BPH or benign prostatic hypertrophy, and they get a cold and they take an decongestant, and the next thing you know, they're now experiencing overflow incontinence or partial urinary retention. So we can't rule out that medications definitely contribute to incontinence, and taking a quick view. So if somebody has a new incontinence, go to that med list and go, what changed? And that's something that I do on a regular basis. How do we treat someone with urinary incontinence? Well, let me just tell you, the most important thing to remember is that it's a whole person, and we need to address all of these factors and look at where in the loop we can make a difference. And sometimes, depending on who our patients are, we may not be able to cure the incontinence, but we sure can change one of these things in the loop to improve quality of life and actually help their incontinence and make it better. So part of the evaluation is looking at as many of these things as we can and trying to make a difference. So the continence evaluation looks at everything in the loop. We look at that history, that physical exam. Now, one of the things I try to point out is that physical exam is really important because we say, well, they're old, we don't really want to look down there. But if they have some structural anatomic abnormality that we can do something about, that would be really important to do that prostate exam, do that GYN exam, look for pelvic masses. We want to make sure they don't have a UTI. We want to evaluate how well they empty their bladder with something as simple as a bedside bladder ultrasound, and if needed, lab or imaging testing. And that's, again, as indicated and at the discretion of both the clinician and the patient and their family on whether this is really warranted at this time in their life. We want to look for reversible causes of urinary incontinence, and we know how medicine loves our acronym. So here's a new one there for you, toileted. And we want to, again, look for those things such as that thin, dry vaginal epithelium, which comes across with symptoms like urgency, frequency, and dysuria. Look for constipation, UTIs, limited activity to the toilet, emotional issues that might impair someone's motivation to use the toilet, changes in medications, endocrine disorders, and I again put the diabetes family down there, and delirium, which incontinence might be the first sign of delirium. I'm put this slide in here as reference to you, and this, again, it's difficult in some populations to make a diagnosis of a UTI, and so to look at what their symptoms are in addition to changes in the character of their urine, because this may be the clues that you need. So what are we going to do? with treatment, I like to divide it into first, second, and third line treatment. And first line treatment is lifestyle modifications and things that we can change. Second would be medications, and third would be such things as surgery, neuromodulation, and Botox. And I'm going to talk about all of these. But I think really what I deal with more than anything else is that first line treatment, those things that we can modify, even if one or two things, to make life just a little bit better. So let's talk about first-line treatment, and those are basically called lifestyle changes in behavioral therapy. And I'm going to talk at length at a lot of these, but these are part of national guidelines with the American Urologic Association, American Urogynecology Association, with the WOCN, SUNA, all of them, and the International Continence Society agrees that this is first-line treatment. So what do we do about fluids? We need to look at fluids. Now, what's frustrating is I was on we did a systematic review of literature looking at fluid years ago, and we wanted to say, well, what kind of fluid or how much affects incontinence, urgency and incontinence. And what we found was something that was difficult to tell to a patient, not too much, but not too little. Well, normal hydration is what we're really talking about. And with some of my patients, it's looking at creatively spacing fluids through the day. I've had patients who were said, my sister-in-law told me I needed to take 3 glasses of water with my medicine in the morning. And then she would drink a cup of coffee, a bowl of cereal, and some orange juice, and she wondered why she had trouble making it to the bathroom in time. And what I needed to do was to modify that to say, well, let's do it this way and then go to the bathroom at this time so that we could creatively space that. We look at caffeine intake. Caffeine absolutely can stimulate bladder contractions and cause urgency, frequency, and incontinence. Watch out for alcohol and soft drinks. And there are so many people that think, oh, this is fine. It's caffeine free, you know. It's diet caffeine free, so it's really healthy. Well, now you've got the bladder irritants of artificial sweeteners. And that in itself can also cause a problem. So I try to say, oh, no. Let's really talk about your soft drink intake, because that may be contributing to your urgency and to your frequency. Bowel management is perfect, and I see that some of you are in hospice and home care, and you are experts at bowel management. And so just keep doing what you're doing, because it does impact the bladder. And there's my little picture that I show how lots of stool content in the sigmoid colon does impact bladder filling and emptying. So we want to look at those basic components of hydration, fiber, time and place. When you get the urge, you answer the urge, which some people don't do. And use of a potty stool, and I have a whole talk also on constipation, but that it's something called the anal rectal angle, which when you put the knees higher than the hips, it actually eases the movement of bowels out of the body. So it's really wonderful. There is a commercial stool out there, but I don't recommend it. I say go to your local store and get one of those little plastic things that you can keep in the bathroom. Nocturia management. Really, when you talk to patients, they're going to complain and say, oh my gosh, I get up 5 times at night, and they're really upset. It really bothers them. And I try to look at what's causing that. That's where, again, I look at medications, I look at past medical history, but there's some really simple things that seem to help and help them a lot. I talk about avoiding fluids after supper or 3 to 4 hours before bedtime. And it's amazing how that will cut down on urine production at night. If the patient has edema, look at maybe elevating their legs before bedtime. I recommend put your feet up on a recliner, put a pillow underneath your feet in the recliner, and that for about 2 hours, read your favorite book, watch your favorite show, and do that like in the mid-afternoon. And it's not going to stop the nocturia, but it certainly may decrease your nocturia by 1 void a night. Compression stockings, if indicated, if they're not contraindicated due to arterial disease, they also might help, because what happens is the fluid mobilizes out of the legs about 2 hours after the legs have been elevated and will really contribute to nocturia. Weight management. Yes, weight loss does impact urinary incontinence symptoms. Bottom line, and it's one of the hardest things to help people to do, but I do bring that up. Addressing functional impairment, looking at mobility, falls, manual dexterity, and manual dexterity. Look at the poor picture of the ulnar deviation there. Do you know how hard it is to manage clothing to you when you're having problems with manual dexterity? Visual impairment, being able to find the bathroom, pain and anxiety can significantly impact your trip to the bathroom. Fatigue and dyspnea, very important to keep in mind. And spacing activities and saying, sometimes we try to help people on our schedule rather than on their schedule. And just pure fatigue may keep them from wanting to go to the bathroom in a timely manner. And of course, any changes in mental status are important to take into account, and I'm going to talk a little more about that. Address barriers to toilet access, and that's simple things like toilet grab bars in the bathroom. Taking away scatter rugs. Boy, my parents hated it when I did that to them. Make sure there's adequate lighting, a clear path to the bathroom. How many of you in home care have gone and you look at where the patient is sitting and the bathroom, and it's not even wide enough to put a walker through that space. Adequate footwear. It's amazing what people put on their feet or don't put on their feet. And modifying clothing. I've actually been called a miracle worker for just recommending, why don't you just wear a sweatpant instead of something with all those buttons and zippers. And it really decreases the time needed to get to the bathroom. Multi-layered clothing. When people are incontinent, they think more is better. So I have seen people wearing not only multiple layers of clothing, but there'll be multiple pads in there. That's the BWAP, and paper towels, tissues. It's amazing what you'll find down there. Prompt assistance for toileting. That's very difficult when someone lives in a group environment. Pain and anxiety management, and of course, referral to my colleagues in physical therapy and occupational therapy for their help with assistive aids. Addressing barriers to toilet access is very important, and in terms of cognitive impairment, looking at memory and do they forget to change their product? Do they have trouble with language and telling you what they need or they want, and they're calling the toilet something totally different or some totally different word? And we need to actually pay attention to that and figure out what that cognitive deficit is. Do they have problems with orientation and attention to a task? How about executive function? I've had a fair number of consults when I was doing urology rounds in nursing home for gentlemen that would void in inappropriate places. And I said, well, you know what? They're not really incontinent. They really are directing their behavior. They don't want to wet themselves. They've just used somebody else's bed or plants or ice machines or things like that. How about apraxis, the use of objects and accurate naming of objects? Do they know how to ask for what they need? And do they recognize objects in their use? I often ask patients, I'll ask the staff, I'll say, how do they do with forks and spoons? Do they know how to use them? And there's some simple things we can do. Written instructions, if they can read. They may have trouble with sequencing, and so we can put the directions in the room. The directions should be simple and clear. They may need step-by-step cueing, when they go to the bathroom. You don't have to touch them. You just have to tell them what to do. When you make signs to the bathroom, put a picture of the toilet, but also write the word toilet. Underwear like BWAP, and underwear like products feel more normal. Put a light on in the bathroom. And always talk to the caregivers. Caregivers, I know that they know what their family member or what their patient really needs. They know their schedules, they know what they need. And toileting programs are really the basis of a lot of this. Let's talk about toileting programs. Okay, toileting programs preserve dignity and quality of life. They help reduce risk to incontinence-related skin damage. What some of the basic requirements is that they need to it needs to be safe to use a toilet or a urinal or whatever, and it could be with or without assistance. And when you take them to the bathroom, they need to void at least some of the time that you take them. And it always requires some degree of interaction with a caregiver. So one of the things that I recommend, and this is helpful when we're looking at fluid intake and it's looking at bladder habits, is to use some sort of a bladder record. It doesn't have to be difficult. It doesn't have to be complex, but this is just a basic requirement. There's a zillion of them out on the internet if you don't have one in your particular agency. Toileting programs, one of the most simplest and widely used in any kind of residential facility, is routine scheduled toileting. It has a bunch of different names: timed voiding, routine toileting, toilet training, scheduled toileting, but whatever. All it is that the person is toileted on a predetermined schedule, such as every 2 hours. And I'll tell you, it works. It works partially, but it works. It helps reduce wetness. It helps reduce skin damage. There's another one that's called habit training, and the other it was first researched by Joyce Calling, who's out on the West Coast, and she called it patterned urge response training. And what it is you use that diary and you try to match your toileting to the patient's own voiding habits. In other words, when they have a full bladder, you kind of track them, and continence basically does improve. This does really work due to good and timely access to the toilet. But consistency is really important. And I have found that family caregivers are absolutely fabulous at this because they don't even need the bladder diary. They already know when their loved one needs to use the bathroom, and some really dedicated caregivers in the home and in facilities, they absolutely know when to take this person to the bathroom to keep them dry. Prompted voiding is the most studied of the toileting programs, and it is studied to be effective. It improves the ability to toilet through consistent toileting and positive reinforcement. And it is a little bit labor intensive, but it requires the patient to recognize common objects and to follow 1 to 2 step instructions. What we do is that on regular intervals, you approach the incontinent person and ask them if they're wet or dry and if they need to void or use the bathroom. You praise them. You take them to the bathroom no matter what, but you praise them for toileting and you praise them for staying dry. And what happens is that positively reinforced behavior will then be established. And there is definitely data to support its effectiveness. Prevention and management of IAD, or incontinence-associated dermatitis, is very much a part of incontinence care of any kind. And it's always a 2-step process: is adequate cleansing with a gentle pH balanced cleanser, and to avoid friction. You don't go rub, 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 because it damages delicate skin. And you need to protect with some kind of moisture barrier. And I'm not going to go at length into these, but just to remember that you need this 2-step process to protect the skin. And some of the most cost-effective are your traditional moisture barriers, which are creams, ointments. And we have things such as zinc oxide and dimethicone creams. And then you have your occlusive ointments such as petrolatum. So they do work, but it's really important that we do this 2-step process for both prevention and treatment. Body-worn absorptive products, BWAP is the new acronym for that one. And I was part of the expert consensus panel for the development of this document, but we looked at all the different things that need to go into a decision on the type of product that you're going to recommend or use for a patient. And that only doesn't include, it includes things like cost and environmental impact, mobility, dexterity, the patient's preference, caregiver issues, functional issues, and also the type of incontinence. And that also involves fecal incontinence as well. I can refer you to the body-worn absorptive product guide, which is free to anyone. and it can go right on your handheld device, and it's a really wonderful algorithm where you can answer questions, and then it'll give you guidance on what product would be best for your patient or your family member. The categories of products were designed by light to moderate urine loss. Just to give you an overview, we have things like pads. There's liners, perineal pads, and inserts. There's also male guards. They didn't call them pads, they called them guards. And these guards are strategically padded for the male anatomy. And you have such things as male pouches. I have patients that love the little pouches, and there's some of my gentlemen that didn't like them at all because they felt they were uncomfortable. We have products for moderate to heavy urine loss and fecal incontinence that includes pads, male pads, belted pads, or as you can see that at the top, pull-on type pads, or we call them protective underwear. We have all-in-ones, since one I didn't have a picture of, which is a wrap. It's relatively new product for gentlemen that are in bed, that it literally wraps across the top of the male anatomy, because that's where they get wet, is on the top. And then we have unbacked pads, which are inserts or booster pads, and those pads are useful at night. When you have someone who is producing large amounts of urine, these do not have the plastic lining on them, so that the urine is just absorbed in the pad and then goes through that to the second product. It's really important not to have patients layer pads, which are regular pads with the absorbed plastic layer, because basically it won't work, because the urine will go around the sides of the pad once it's full, and they'll still wet the bed or their clothing, and they get very upset about that. Now, I can't say that it isn't me if I didn't talk about pelvic floor muscle exercises. The oldest person that I've taught this to was 94 years old. So there's no age limit on this one. The exercises increase pressure on the urethra, and they help inhibit bladder contractions. They reduce things like urgency, stress incontinence, urgency incontinence, and there's growing data, which is very exciting, that it can actually impact pelvic organ prolapse symptoms in women. So I think this is like really important. If you even in a little way, you can help your patients by improving their pelvic muscle strength if they're a candidate for that. Well, as everybody sit up, all right, now's your time to exercise with me. So first step is to locate the pelvic floor muscles. Now, how do I tell them to do that? Or how I'm going to tell you is first squeeze. Everybody's sitting with your feet comfortable on the ground. Okay, you got that? I want you to squeeze like you're holding in gas. And then you move that squeeze forward. And with women, it's sort of like an up and in sensation. For gentlemen, it's kind of a lifting of the scrotum. Okay, did everybody get that? Okay, now what you're going to do is you're going to squeeze that muscle. You're going to hold that squeeze up to 10 seconds. If you haven't been doing these for a while, you're not holding it for 10 seconds. I guarantee it. It's something you're going to have to move up to. Then you're going to relax for 10 seconds, a count of 10. And when you get we're going to keep doing these exercises for 10, repeat this cycle for 10 times and about 3 times a day. What I have people do is they start maybe holding for 2 seconds and resting for 2 seconds, doing it 10 times in a row, 3 times a day, and then gradually increase it. And believe me, they do notice the difference in terms of urgency and frequency and stress incontinence. So it really does work. Now, this is one that's fabulous. Anybody can do this. This is great. Try it. You will love it. And what it does is it's called the knack, and it's the squeeze when you sneeze, but boy, does this work. So it's a contraction of the pelvic floor muscles that increases the stiffness or the underlying support of the urethra. And that contraction increases the pressure inside the urethra. So this is like fabulous. See that little picture there where one's kind of loose and the other one's nice and firm? Well, that little line across there is the pelvic floor muscle. So Before you cough, before you sneeze, before you bend over, you do a quick squeeze as hard as you can. Boy, this works. It works great. I have people that just love it, and it works right away. And the stronger your muscle gets, the better it gets. And this is something that you have somebody that leaks when they get out of a chair. You go, all right, before you get out of the chair, squeeze as hard as you can and then get up. And it sometimes decreases the volume of the leak. Sometimes it stops the leak altogether. Now, here's the next trick for you. This is urgency training. Oh man, you will love this. Okay, this is that gotta go that is so panicky. So what? To avoid rushing to the toilet, you really want to avoid that because that increases anxiety. So to control the urgency, you ready? It's like a trip up a mountain because you have this terrible urgency and you need to get to the toilet, which is up near the top. Okay, so you take a few deep breaths, 2 to 3 deep breaths. You relax. You do those pelvic muscle quick flicks. Oh my gosh, there we go. There we go. Do 6 of them. That's great. You take your mind off of that urgency, and that's really hard to do, but boy, does it work. And those of you out there that are nurses or mothers or parents, you know what it's like to defer voiding because your mind is just a million other places. Okay, and then you wait till the urge passes, and then you go to the bathroom. And bladder retraining involves lengthening the time gradually between bathroom trips. This is fabulous. It's hard to do, but boy, does it work. And if you're in a long line to the bathroom, try this. I'm telling you, you will love it. All right. Another thing that might help with incontinence is if the patient has a pelvic organ prolapse. And I just put that in here as a reference, but their pessaries, I had a huge pessary practice, and there's all different shapes and kinds. And what they do is they support the bladder, and some of them support the urethra. I've had patients that I have fitted with a stress incontinence pessary, and their stress incontinence went away. But like everything else, there's pros and cons with this, and the patient may need to be very carefully evaluated. It is not something you put in and just leave. They requires office trips. There are complications that need to be taken into account. So, but for some patients, they're a game changer. They're really a game changer. Male external collection devices, I'm not going to spend a lot of time on there, but I wanted to make sure that you had this information to know that there's 3 different types and that they are an option for some gentlemen. There's external urine collection suction devices, and I don't know if you are familiar with that. They are now available at home. They've been in the acute care setting, but it uses wall suction, and this little device for women sits right next to the vulva. There is a male device out there, and this device actually sucks the urine right away from the skin. Some patients absolutely love it. So there are some contraindications for it. There are some things that we need to keep in mind, and I've listed them on the slide for you. Second line treatment. All right. So what we have here is pharmacologic options. And one of those is there are 2 medications available. And to date, there are still no pharmacologic therapy for stress incontinence. It just doesn't exist. And there's really nothing really super effective for urinary retention. We have a few things out there that are being used by urologists, but if they work right away. If not, maybe not. So let's talk about where they work. Well, we've got is 2 classification of drugs. We have the Anti-Muscarinics, which inhibit receptors that prevents contractility. So overactive bladder, you see how they would work. The other set are the beta-3 adrenergic agonists, which activates receptors during filling, which so technically improves filling. We have a third group, which are your alpha adrenergic blockers, which are those medications that we use for BPH. So as we look at those, let's look at these medications. So the old and trues here I've listed for you is the current anti-muscarinics that are on the market for today. And the first one on the market was oxybutynin, and they are effective. There's no data that they're effective. They are absolutely effective. Here's the problem. They have a significant potential for adverse effects. And some of the research that has been recently coming to light is that the anticholinergics, not only the overactive bladder drugs, but also others, have the potential to contribute to permanent long-term cognitive impairment. So we already know that it can cause dizziness, sedation. We also know that they can cause delirium, decreased concentration, forgetfulness, and confusion in some patients. It can affect the eyes. You don't use them with narrow angle glaucoma. It can cause dry eyes. Dry mouth is very, very bothersome with these medications. Constipation and urinary retention are also some of the issues. So it's a very careful discussion that you need to have with patients if you're going to consider the anti-muscarinics, and make sure that the decision is shared with them. The other set of drugs are beta-3 adrenergic agonists. The first one on the market was mirabegron, and just recently bibegron has come out and are out on the market. These medications are very effective. Mirabegron has a slight risk of increasing blood pressure with hypertensive patients, and vibegron does not seem to have that effect with it. But the one problem that we have with these two medications is that not all insurers will cover them, and they're expensive, and that's because they're relatively new medications. Vaginal estrogen is also an option for older women who specifically do have that urgency and frequency. It is more effective than oral estrogen. It is not the same thing, and it has a very low risk profile. And there's very little systemic absorption of this medication, but it is controversial in women with estrogen-dependent cancers, such as breast and endometrial. And with breast cancer patients, I used to have them go and talk to their oncologist about it to see what they felt, if this was a reasonable risk for them to take. Third line treatment. Third line treatment is neuromodulation, Botox, and surgery. Let me talk about percutaneous tibial nerve stimulation. I did a lot of this. It's called PTNS, and you can see there's a little circle there with a foot in it. And what we would do is we would insert an acupuncture needle, and it would stimulate the tibial nerve, and it, over a period of time, the patient would experience decreased urgency, frequency, urge incontinence. And some of my patients loved it because they failed medication, and this worked. Now, the problem is it's 12 treatments, 12 weeks in a row, and then maintenance therapy every 4, 6 to 8 weeks. Now, I just saw that the FDA just approved an implantable device, which it's about the size of a nickel, so that the patient could use surface electrodes to stimulate the nerve, because that little nickel thing is in there. So that's really exciting, because that means the treatment could be done at home. But it wasn't in a certain population. It really worked well, and I had a cohort of patients that really loved it. We got to know each other because I'd stick the needle in and we chit-chat. So it was really fun. Sacral nerve stimulation is like a pacemaker, and it's a surgical procedure. The patients get like a little like a cell phone. It's like a smartphone that they can program the device, and it works very well with urgency, frequency, urge incontinence. It also helps with bladder pain, and with older models, they cannot have MRIs, but the newer models, they can. Now there are MRI compatible stimulators, and now I understand there's now going to be a battery rechargeable device, which is kind of helpful, because the original ones, you needed to go into surgery when the battery would wear out. So this is another option. I've had patients do fabulous with these devices. Botox. Botox, you'll hear a lot about Botox. We're using Botox for just about everything, it seems, but we are using Botox quite successfully for overactive bladder, and both overactive bladder dry and overactive bladder wet. And it reduces bladder muscle activity. It reduces the contractions. The downside is that the patient they do these injections by cystoscopy, so that a cystoscope needs to go through the urethra, and they give the injections into the bladder muscle wall. There is some risk of urinary tract infection, and there is a small risk of urinary retention. And the treatments do need to be repeated. I've had people that have gone as long as 2 to 3 years from injection to injection, others that it's 3 months. So I don't know, why that is with some patients, and others it's just sort of how it is. But for some patients, this is a game changer. This really does make a big improvement when they're suffering from such severe overactive bladder symptoms that is not responsive to medication and behavioral therapy. Surgery for stress incontinence is an option for some patients. There are a number of surgical procedures out there. You've heard about some of them. And certainly if that's the option for your patient, there are procedures out there for the patient, and refer them to a surgeon to do that. So I want to thank you very much for asking me to join you. The take-home message here is we may not get full continence, but boy, if we can make people better and improve their quality of life, I think that really makes the difference. So I think I'll have some time, to do some questions. And
Absolutely.
Thank you for the privilege of being here.
Well, Donna, that was just fabulous. And we do have some questions for you, but before we do, I want to thank you again, because we've wanted this topic for a long time. And you really delivered, and you had to go fast because you had such great information to share. But everybody, you have your slides, you have the information, and you also are able to contact the speaker if for any reason you need something clarified, or if we don't get to your question today. So let's go ahead. Let me see what time it is. I think we can just go. Maybe I better do a quick thank you to our sponsors, just in case we run over time. We are so appreciative of Care Choices, Hospice and Palliative Services, O'Connor Mortuary, Comparing Companions at Home, and of course, our own Alzheimer's Orange County. Please mark your calendars for the next webinar. It will take place on Tuesday, April 12th at 11:30 Pacific Standard Time, and the topic is the PULSED form, what it is and how to use it. So the physician's order for the orders for life-sustaining treatment. We'll learn all about that from our own Patty Mouton. So save that date for next time. Now, let me go ahead and open up the question box and see what kinds of things are on our attendees' mind. Thank you for having this session. Absolutely. You are absolutely right. The impact of urinary incontinence goes far beyond the patient. Enjoying your presentation. Question, can obstructive sleep apnea contribute to increased urine production?
Absolutely.
Great question.
Absolutely. And that is something, because there is something called, there's a hormone that is produced in the aortic arch, and it actually causes nocturnal polyuria, which is a fancy word for saying, pee a lot at night. And what they do is they produce so much urine. And I often would have in my plan, I should have included that, geez. So I often, if they have obstructive sleep apnea, that's in my plan with them, and to ask them, are you using your CPAP? Because it won't solve it completely, but it absolutely decreases the volume of urine that they produce at night. And it has nothing to do with their bladder, it just has to do with urine volume. Good question.
Wow.
Great.
Yeah, thank you. That question got answered. Does the cause include when you have a total hysterectomy and your bladder drops down? Does that cause urinary incontinence?
That's a difficult question to answer. There is an association. I had a lot of patients where once we reduce the prolapse, in other words, if there was a prolapse after the hysterectomy, that the prolapse itself could be irritating to the bladder. Sometimes women that have a prolapsed uterus and prior to surgery, they have a lot of urgency and frequency. And after surgery, after the trauma of surgery, they gradually get better. I think I've definitely seen a relationship between the two of them, but it's not a given that someone will have incontinence or urgency and frequency with prolapse. But I do see a strong association.
Thank you, Donna. This is something about an individual case, and so of course these are always difficult when you're not able to see the patient. But my husband is in-home hospice with Alzheimer's. He's continent during the day, not so much at night. On rising to use the bathroom at night or first thing in the morning, he has a dribble problem. He moves very slowly, and between the time he slides down his PJs and his Depends and the time he actually seats himself on the toilet, he's dribbling. PJs that were dry when he got to the bathroom get wet when they're around his ankles. So what about the dribbling problem, Donna? Is there anything you can say in a general sense?
Well, to believe it or not, it's not something I haven't seen. Okay. And without seeing him, I can't say why he's exactly dribbling, but there are a couple things that I might recommend is that for first thing in the morning, voiding, I might ask him if he could use a urinal for that initial first void in the morning, because that he may be over full and he's trying to hold it and he can't because it takes him too long to get to the bathroom. And you know what? You don't have to have Alzheimer's to have trouble getting to the bathroom early in the morning if you've got arthritis. So, without knowing for sure, that might be one solution, because it's taking him too long to get there. And he may have a very full bladder, which is common in the morning. Because if he's not dribbling other times of the day, it may be that. It may be he's just plain over full.
Very good. Thank you, Donna. This is a great question. What verbiage can we offer to clients who could benefit from an assessment, from the assessment process that you described? So how can we frame that to clients so that they'll accept it?
Oh. Yeah. And gosh, that's a tough one, because sometimes explaining to them that there's many different causes of the leakage, and that it may not be something, it may be something we can do something about. And because the emotional and psychological baggage of incontinence is so huge and so heavy that patients often feel it's their fault. And it's not. It absolutely isn't. And I've had patients actually in the office burst into tears saying, well, you talk about it like it's any other problem. And I said, well, it is any other problem.
Mm-hmm. Mm-hmm.
But, you don't go in with unrealistic expectations as well, because, but if you say there might be something that can be done to make your life a little bit better. And that's what I would recommend, just try to say, it's not your fault. There's could be something we could do better to help.
I think that's perfect, because I'm sure some clients don't think there is a solve for this problem, that it's just they have to expect it in old age and they have to live with it. And to be able to suggest to them that there are a number of different strategies that might potentially help, that could be a ray of hope to them. So that's great. That's
Yeah,
great.
sometimes it's just that cup, that whole pot of coffee they're drinking every day, Having somebody
Yeah,
else tell them not to do that sometimes helps.
yeah. Okay, Donna, remind us, what's a quick flick?
Okay.
It sounds painful.
A quick flick is a very quick pelvic muscle contraction. Squeeze and let go. Now, if you're doing this in your chair, then you're doing it wrong. But it's a very quick squeeze and let go. And I'm telling you, with that urgency, you look at my handout and you follow that. I'm telling you, you'd be surprised how you can get to the toilet in time after you've had 5 cups of coffee. Believe me, it does help.
Great. Oh, here's a statement that I love. Would you touch base on the importance of not calling things like depends diapers to preserve the dignity of the patient?
I'm going to say you and me are best friends, whoever said that, because
That's great.
I will never, if you notice, did I ever once call it an adult diaper? And I won't, and I refuse, because it really does take away from the dignity of that person. It is a containment product. I like the acronym that we came up with the WCN, a BWAP. Who in the heck knows what that is? But it's a product, it's a containment product, it's an absorptive product, but it's not a diaper. So, no, I agree. You get yay on that one.
Yeah, and sometimes even if you just call them underwear, especially those pull-up products. When I was caregiving, I said, let's put your underwear on before
Yep.
your
And that's why
pajamas.
they're called, believe it or not, their official name is protective underwear.
Yeah, great.
I mean, there's a reason for that.
Makes sense. Okay, what is the difference between wet and dry incontinence? And as I'm asking this question, I'm seeing that it is 12:30 now. I know some of you will be having to leave, but do make sure you've had all 60 minutes of the webinar and recognize that you will get your evaluation via email. Okay, go ahead. The difference, Donna, between wet and dry incontinence.
Well, it's not wet and dry incontinence, because incontinence is always wet. But what it is, it's okay. What we're really looking at is that OAB, overactive bladder dry, which is that urgency frequency kind of syndrome, and OAB, overactive bladder wet, which is urgency frequency and urinary incontinence. And the wonderful reason to really look at the two of these is that OAB dry is incredibly difficult for a patient. If you think about it, or a person, I don't care who it is, think about living your whole life always feeling like you have to void. That's miserable. That is really miserable. And so, we don't often think about it that way, but I think that's something to quantify it that way, to say, yes, this is an important thing to quantify. So I have just seen so many patients in agony with this. I mean, they live for the bathroom. They know where they all are. They call it, toilet searching. They know where they are. And the hard part is I do too, because I'm always so aware of my patients. I don't know why strangers always ask me where the bathroom is, but for some reason I always take note of where they are, because people seem to ask me. So it's this toilet searching behavior is all based on this OAB symptoms of urgency and frequency, which is terrible. It's really terrible. So I just love it when people come in and give you a big hug and say, oh, I could spend an hour, or I went to the movies and could watch a whole movie. That's huge. It's huge.
We
Okay.
also, no, that's important. I'm just reflecting upon the fact that we often have folks living with dementia who are worried about having about the bathroom, and so they want to go to the bathroom every 10 minutes, and that can be very frustrating for the caregiver. But
and part of with dementia, one of the that's where sometimes I used to work with the psychiatrists, because some of the medications that we use have anticholinergic effects and can help because we don't always know if it's a behavior because of anxiety, or is it truly overactive bladder? And sometimes one of the things that I would look at in those cases is I'd watch to see if they could get through a meal. Like if they can get through a whole meal without getting up to go to the bathroom, because sometimes that's a prolonged process of being at a meal, or can they sleep most of the night without getting up? Now, there's a lot of reasons why people with dementia get up at night, so that's another whole problem. But if you look at some of those things, it might give you a clue on whether it's their bladder or it's a behavior, or unfortunately, it could be both. So it's a very difficult problem to solve, very difficult.
Okay, we've got too many questions for our time frame, but I'll keep going for a few more minutes. Is there a recommendation for overnight incontinence briefs? Most 6-bed care homes do not have awake overnight staff, and residents often need to wait until morning to be changed.
Yeah, there are overnight products there. If you go to the BWAP guideline, it'll give you, there are actually high absorbency overnight products. Here's the big problem is they are really expensive. And the other thing that I would recommend as well is an insert or a booster pad. I wouldn't use it during the day, but I would not double the product because of the plastic lining, but I might put an absorptive pad inside that's designed to be a booster pad. It's unfortunate, but what you want to do is keep the urine in the product so it's not onto the bed or the sheets, which makes the patient very uncomfortable and cold and damp, and the absorptive products are designed to wick urine away from their skin, so you have a little bit of better skin protection that way than to have just wet sheets or right on their skin. So it's a hard problem. It's a really difficult problem.
Thank you. What is it that you mentioned can decrease the amount of urine when urgency to pee wakes people up?
Fluid management is really important. What do you drink before bed? Avoiding caffeine. Some people have coffee before bed. That's amazing. You really want to avoid that. Trying to limit fluids within 2 to 3 hours to up to 4 hours before sleep. There's people that keep water glasses and water bottles beside their bed, and every time they wake up, they drink more water. I say take a sip, but don't drink a lot of water during the night. It might help. It's a difficult problem because it's a urine volume problem sometimes, and sometimes it's not. It may be overactive bladder.
Thank you. Do prostate cancer and testicular cancer exacerbate urinary incontinence? What recommendations do you have, if any?
That's a loaded question because I don't know if the cancer is spread. Is there local expansion to the bladder in that area? Well, that's a whole different ballgame. Yeah, that can impact bladder function. If it hasn't spread, if it's been well localized, it may not have anything to do with the cancer. So it's, without knowing the particular patient's case, I really couldn't say for sure, but it really depends on the type of the cancer, whether it has local expansion to the contiguous areas, especially with the prostate. Testicular, not as much, but you might want to look that way.
Thank you. Someone's recommending a Seni product, SENI, fabulous for nighttime.
Well, you better send that to me in an email because I'd love to know what this I'm not familiar with that. That's great. Send it to me. I'd appreciate it. At least a reference to it.
And then what is PVR? Can you remind us?
Post-void residual. How much is left in the bladder after voiding?
Okay. Okay. All right. Well, we're standing at about 20 till, and so I think I probably need to end this question and answer dialogue, and I know some of you will be disappointed because I wasn't able to get to your questions. So just be aware that Donna has generously agreed to answer your questions via email. So you see that on your screen. Again, we thank our sponsors. We thank all of you. We most certainly thank our speaker. And as one of the attendees just said to me in the chat box, I had no idea this subject went so deep. So I think that a lot of people are on that in that boat, and so we've certainly learned a lot from you today, and thank you so much. As I get ready to close the webinar, just be aware, everyone, that we have tons of great virtual education classes that are available online. Just go to our website, www.alzoc.org, and sign up for additional classes. And hope to see you next month for a discussion of the PULSed form with our own Patty Mouton. That'll be Tuesday, April 12th. Okay, and with that, I'll say good day to everyone and thank you for your participation. Thanks again, Donna.